Assala- Assalamu alaikum. My first question, Zishan, is to you. Okay, I will share the question. And okay, so can you see the screen? Um,
Yes.
this is a 28-year-old primary gravida who is booked for elective cesarean section. Okay, she has cephalopelvic disproportion, and has placenta previa type 4. So first question is that what preparations you need to do for this patient? Yes, Ishan, can you hear? Yes.
Yes, sir. Sir, this is an elective C-section. So the patient must be already prepared and already ready for the operation. She must be NPO. As this is a placenta previa type 4 patient, there is a greater risk of hemorrhage, peripartum hemorrhage, antepartum hemorrhage. So we should be preparing for the blood bank. We should notify the blood bank and have at least 6 units of cross-matched blood.
Okay.
Which this is before going to the OT. Of course, we should be
Okay.
now. And as there is more risk of hemorrhage, so the hemodynamics might be will be a chance of hypotension. So we should prefer general anesthesia for this patient over regional to have a more good control of hemodynamics. So according to for GSR, we should first of all have two large bore IV lines of 14 gauge. We should give this patient the sodium citrate, 30 ml of 30 mole sodium citrate for anti-SID prophylaxis, and before moving to the theater.
Sodium citrate.
In the yes, sir.
Okay.
In the
What else?
theater, as we are going for general anesthesia, there is a risk of difficult intubation due to the obstetric patient. So we should have at least 2 anesthetists. One should be a senior one, and we should have all the gadgets and equipments available to tackle with difficult intubation.
Okay.
I think then obstetrician should be, of course, the obstetrician would be there.
Okay, I'm just giving you a hint. What teams would you like to discuss the case?
This case should be discussed with the neonatologist, obstetrician first of all, then the neonatologist, hematologist, and the critical care team.
Like an ICU,
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 what else?
blood bank,
Blood bank,
and the gyne ops people.
okay. Gyne ops. What else? Is there any
I
association
think
other
that
than placenta previa with this? Is placenta previa maybe diagnosed at something else? Or would you like to, in the preparation, would you like to have something additional which you did not prepare? What about consent for hysterectomy?
yes, sir. Right.
Okay. What about preparing for, you said only hemorrhage. What about anything else?
Cell saver, of course. Okay, those things
No,
become
those things have
necessary.
numbers. Okay.
Yes, sir. Right. Cell saver and blood saver.
You don't need to tell about
Level one
sodium citrate.
infusion.
That is not that much important thing than this patient with greater risk of bleeding. Okay. So you have to tell about cell saver, you have to tell about warming device, you have to tell about rapid infuser system, you have to tell about all the possible things which may be needed. Okay.
Sir.
If there is association, even they have mentioned here, but there is association of placenta previa with other terrible placentas as well. Okay,
Yes, sir.
so you can tell about that there may be association. So if there is any possibility, you might need to have internal iliac vessels embolized by the interventional radiologist. Okay, you should have adequate amount of blood and blood products. You might need to activate massive transfusion protocol intraoperatively if the products which you arranged failed. Okay, so massive transfusion protocol, the operation theater team should be ready. You should have like all the environment ready for any possible maximum sequelae. Okay, so in addition to that, you can just mention in that way that all the possible things which are there because of physiological, pharmacological, anatomical changes in a pregnant patient, because that leading to difficult airway and aspiration risk and all the respiratory, cardiorespiratory parameters which are different in that patient. There is risk of amniotic fluid embolism, there is risk of pulmonary embolism, there is altered and response to anesthesia and lowered MAC. So these are the common things. You can finish this answer in few seconds, 5-10 seconds. You can finish the concerns related to pregnancy. Okay, and if they want to ask anything in detail, they will go into it. The things which are what are the surgical consideration which you need to consider or which may be needed. What are the anesthetic techniques which you need to use to control bleeding? So you have to tell these things. Okay, and for that you can tell even you can pass in this question, even in this preparation, if you target systematically. Operation theater, other teams, operation theater environment, anesthesia preparation, hypothermia, and all the things which are related to it. Invasive monitoring because of rapid swing of. You only told about large bore IV cannulas. You did not mention about difficult IV lines. Sorry, you did not tell about invasive monitoring. Okay, you did not tell about that. You will be trying to avoid the factors which can increase the bleeding. Okay, the uterotonic medications. You did not name anything. These are preparation. You have PGF2 alpha. You are not using in every patient. Am I right?
Yes, sir.
And even the other thing, methergin and this ergot, you are not using in every patient. Okay, so you have to tell about these things that you can make in a heading, because this is a question which will be asked in every second person. Okay, either bleeding, either hypertension. Okay.
Yes, sir.
So I hope you understand what were the mistakes you did, and you have to prepare ICU. You have to take the consent for hysterectomy, and the other surgical techniques which I was telling you is B-Lynch is one thing.
Yes, sir.
Massage is other thing. Okay, and you have
Bimanual
to
pressure.
you also have to tell in the anesthetic factors that you will try to even reduce the MAC, or even you have you can convert it into TIVA for that time,
Viva.
to avoid any factor which can exacerbate the uterine relaxation. Okay,
Yes.
so these were the deficiency. Rest of the things you told, but actually you know you will be caught in the first answer you said. This is a killer answer which you said. It is already prepared. What do you mean by already prepared? They want you to speak out. Okay, in the exam you think you are talking to your baby, and your baby doesn't know anything. Your baby doesn't know what is placenta previa. So you have to tell that in this answer, if you will start that this is a high risk patient for bleeding, there is concerns related to anything which is related to pregnancy, and one thing is pregnancy, other thing is bleeding. So these are the headings from where you can start. So bleeding, controlling the bleeding, avoiding the factors to bleed, and blood products. These are the three things. Then surgical, among the surgical, I told you. So this is how you have to target this question. Am I right?
Yes.
So who is the second volunteer? Sahrish, you want to answer?
Yes, sir.
Okay. So the scenario for you is Okay, so you are being called in emergency to evaluate a 28 weeks pregnant, 32 years old patient, okay, with eclamptic fits. Okay, so what will be your first response? What
Okay,
will you
sir.
do?
Sir, on approaching to the patient, she will be in the ER. So my first approach will be to check ABC,
Okay,
as the patient is having the acute complication right now, and
okay.
that is the fits. So, sir, for controlling the fits, we have best option is magnesium sulfate. The loading dose
What
of which is 4 gram.
what
Yes.
may be the manual
After
for
my
ABC? You only said ABC.
Okay, sir. Sir, I will check the airway. If the patient requiring the management of airway, I will put the 100% oxygen. Or if she requires the intubation, I will perform intubation. Two large IV cannula. I will to call for the help first, and after call for the help, I will check the airway and breathing pattern of the patient. If she 100% oxygen, pass to a large IV bore cannulas, and then give her the
Your voice is distorting, Sehrish. Unfortunately, your voice is not coming clear. Your voice is not clear. Sehrish, your voice is not clear.
what are the vitals.
Sehrish,
And
apologies, your voice is not clear. We are not
okay, is it
able to.
okay?
Is it? It's better now.
Hello,
Yes,
is it okay?
yes, yes, yes. Please.
Sir, is
Okay.
it okay now?
Yes, yes. It is better now.
Okay, sir. I will check the air. I said that I will first call for the help. Then I will see the ABC, in which I will check the airway, her breathing pattern. If she require intubation, I will ask somebody to help me, and I will intubate this patient. I will check the monitor. I will check the monitor ECG, BP, oxygen saturation, and I will prepare pass her to a large IV bore cannulas
What
to
are the
and
what are the risks which may be there when the patient is fitting? In airway, you have to mention one more thing which you have not mentioned, is you have to avoid the tongue bite.
okay. I
Okay.
will pass the Gittle's airway, right?
Yes. Okay. You will try to put the and
For that, I will pass the
yes, and
Gittle's
there is
airway, right?
risk of aspiration. Patient can aspirate at that time. So accordingly, you will be doing that. Okay. So control of
Yes.
the fit. How will you start magnesium sulfate?
Sir, I will give 4 gram stat, then 1 gram per hour for next 24 hour. And if she's still fit, then further give her the 2 gram
How to monitor?
stat, and then one.
If you have started magnesium sulfate, would you like to do something before you start, or you will start straight away?
Yes, I will. Yes, I will send some labs, including the magnesium level.
Okay. And how will you monitor? How will you monitor the magnesium levels?
Sir, hourly तो हमने भेजे sir, 2 hourly.
What do you
We used to send it 2 hourly.
What do you want to do other than levels?
So basically deep muscle reflexes. Check
Yes,
करेंगे.
muscle tendon reflex.
Yes, muscle tendon, respiratory depression, cardiac arrest, ये चीजें होती है hypermagnesium में से. तो I will going to check these all things.
Okay, would you like to see the urine output or no?
Yes, I will. I will pass the Foley's catheter and
You will monitor
check.
the ECG. Okay, you will monitor the
Yes,
ECG. You will
ECG.
monitor the urine
Yes,
output. You will monitor the deep tendon reflexes. Okay,
deep tendon reflexes.
and you
Yes, sir.
said 4 gram magnesium sulfate over how much time?
In first 2 hours, and then 1 gram per hour for next 24 hours.
IV or IM?
IV, intravenous.
Okay. What else? If you are in addition to magnesium sulfate, what are the other options which you may needed at that time?
Sir, for
How
control,
much?
if her blood pressures are not controlled, they are raised. So I am going to use the
So did you?
blood pressure
So,
controlling.
so did you tell anything about blood pressure? You did not tell anything.
Yes, sir.
Okay. So when you are telling about
Yes, sir.
ABC, ABC is not answer. Okay. Airway breathing circulation. I will make sure patient's airway is patent. I will put the bite block and I will do the suction and I will see the other vital signs. Okay. And
Yes, sir.
other possible complication which can occur at that time. That is hemorrhage. That is hypertensive, any if you can just please ask the you see there is so much voice. Anyways, so you will be controlling the airway in the breathing and then circulation. You will see the blood pressure. So your aim will be not only controlling the blood pressure and also controlling the fits. So you will be starting magnesium. What is the mechanism of action of magnesium for controlling fits?
Mechanism of action.
Zishan, what is the mechanism of action? Okay,
It has a membrane stabilizing effect.
Membrane stabilizing effect, and so it is not immediately that magnesium is not. So you have to tell that I will be loading the patient with magnesium sulfate, taking the levels and mechanism to monitor the magnesium toxicity, and in addition to that I might need to have benzodiazepine, phenytoin according to the scenario. Okay. In addition to that, I will be starting labetalol or nitroprusside or hydralazine to control the blood pressure according to the scenario. Okay. So you have to use another answer which I tell many times. Resuscitation, management, and evaluation will go side by side. Okay. So what will be your next priorities? Yes, Sahrish, continue the answer. What?
Yes, sir.
Okay, you stabilize the patient. So what are the next things you want to do?
Sir, I will involve my other colleagues to call for help from the ICU or arrange ICU, inform the obstetrician to come and quickly review the patient, and call for the neonatologist to come and check for the baby's condition.
No. At this time, what is the need for neonatal? Baby is still in the belly. So your
yes.
answer should be that you will be discussing the patient. What is their plan? Okay. So there are two lives.
If
two
they want
lives.
to terminate
you will
the-
be
yes, if they
you will be discussing with the obstetrician what's their plan. Maybe they will consider to give dexamethasone for the lung maturation. You will be discussing with the ICU team that my patient might need to be shifted to ICU. Then if in case they are planning for cesarean section, in that case you will be going to you will be discussing
prepare
with
the
the
patient
NICU.
accordingly.
Okay, because if the patient is 28 weeks, baby definitely will need an ICU care. Okay,
Yes, and ICU.
but deciding for cesarean section is not your domain. Okay, you will be
Okay.
discussing with the obstetrician and what is their plan. So you will be using like this, that according to the scenario, if the patient is you are able to control the things, then they will continue to the maturation of to continuing the pregnancy. So either they will be terminating the pregnancy and going for cesarean section. So in that scenario, of course, if the patient airway is already because you did not say
Secured.
that presented with eclamptic fits, that you will be controlling the fit will be first priority in addition to airway breathing
Yes.
circulation. Okay, maybe patient was having fits before and now patient fits free. Okay.
Okay, sir.
So you will be evaluating you use this word that I will be your evaluation, resuscitation, and management will go side by side. This answer will
Okay, sir.
cover everything. Okay. So
Okay, sir.
the things these are the possible questions which they can ask. How will you?
Yes.
How much labetalol will you give? How much benzodiazepine will you give? Which benzodiazepine will you give?
Okay.
Okay. So for magnesium, don't let them ask. Just say that whenever you are starting the magnesium, you have to send the baseline levels and you will be monitoring for the toxicity. If the patient does not
Okay.
have the urine output, giving magnesium is a very dangerous thing, because it
Yes.
can cause, in that scenario you will never you started the answer with the bookish 4 gram stat tha. And the examiner will twist your neck and twist your arms if you start your answer like that. Okay, that's why I say that the more you try to come out of the book and answer logically, you will be passing. if you are trying to just reproduce the book, there are more chances of you to fail. Okay, so just try to save yourself. That's what I message I want to say. Okay, so in this patient, you will next step will be, and if it is a scenario based question, otherwise they can ask you. These questions can be coming in different scenarios. The other thing which can what is difference between preeclampsia and PIH? What is PIH? What is preeclampsia? What is eclampsia? What is HELLP syndrome? Okay, so they can,
Yes, sir.
if it is there is no proteinuria, it is PIH. If they become
yes.
patient becomes symptomatic with headache and any other systematic involvement with proteinuria, okay, and edema, then it is and after 20 weeks of gestation, so it is preeclampsia. Okay, so they can ask you what are the systemic involvements, what are the diagnostic tests, how much proteinuria, and they can ask you about this thing. What is HELLP syndrome? I cannot tell you each and everything, but if fits occur, it is eclampsia. Okay, so these are the possible questions they can ask you: how to diagnose, how to manage, what are the systemic involvement, and then in that way, then they will be asking you, either you will be proceeding for GA or spinal. So if you have a fits-free patient, would you like to consider GA or spinal? And how actually you can say either, and then you have to defend. So what are the advantages of giving GA in this patient?
Advantages will be, if she fit in middle of the surgery, it will be helpful for us. And if
Okay,
they
this is
want
one
to
thing.
and if
What
they
else?
are going to
It better than this one is that there is the better answer will be in general anesthesia. There is a better control of airway. Okay.
Yes.
Rather than saying if the patient start fitting, this is also correct, but it is better if you say that there will be better control of GA. But what are the problems associated with GA?
Hemodynamic instability.
Better answer.
Of the uterus.
Hemodynamic instability occurs more in spinal as well. If you give spinal to a patient with you can say that there will be exaggerated laryngoscopic stress response. Okay, so you have to tackle with the laryngoscopic stress response will be exaggerated, especially in the patient with hypertension. Okay, so that will be one thing. There is risk of aspiration. There is anticipated difficult airway in a pregnant patient, which will be even further deteriorated in the patient which can fit. So during intubation, patient can having fits. Okay, so you and there may be sudden hypertensive crisis. Okay, so you have to this thing. Then other thing is that there is exaggerated response of neuromuscular blocking agents because of magnesium. Okay,
so delayed recovery is also the
delayed recovery is another problem. Okay, polypharmacy you are giving. So these are the things which you can say in against GA. And advantage of spinal or epidural is that you will have a stress response, so blunting of stress response, but the problems are related to coagulopathy. So spinal is advantage is that the needle is small, so less chances of this hematoma, but more sudden because these patients are volume depleted. So if you give spinal, there will be sudden hypotension which can occur. In epidural, there is better control. Even you can say that in addition to GA, you can give epidural for the hemodynamic control, blood pressure control, and postoperative analgesia. You can give even GA with epidural with GA. Okay.
Okay.
But if you are giving epidural, you have to rule out coagulopathy. Even if you are anticipating coagulopathy, you can say that if there is any doubt of possible coagulopathy, epidural will be, and you will be considering this sentence will also help you again and again. I will outweigh risk versus benefit. If there are more benefits than risk, I will consider that thing. Okay. So like benefits of blunting stress response, analgesia, this, and versus the risk of coagulopathy. Okay. So this is the answer. Just tell me one thing. In which book this answer is written?
Nothing. No, sir.
Thank you very much. In the exam, that's why you have to throw the bloody nonsense books. You don't mind my words, but that's a reality. That the failure in Viva for people is not that they are reading books. It's the reason is that they are reading books only. and they are not trying to use their brains. They have switched off, because you see what you did. You just throw the 4 gram magnesium sulfate without looking at anything else. That in the exam they are expecting that when you are telling that I will be starting magnesium, they are expecting that as a safe anesthetist you will be discussing, you will be looking at evaluating the patient about the possible arrhythmias, about the possible toxicity. So if you tell them, okay, fine, the answer is correct. But if you are not telling, like if you are sending a baby to a young child to the kitchen without knowing how, whether he is able to switch on the stove or not, it will be a dangerous thing. Am I right?
Yes, sir.
So that's in the exam they pass or fail on the basis of how safe you are. If you are a safe anesthetist, they will never fail you, I guarantee you. Okay, so who is the third person here? Sidra, you want to answer?
Yes, sir.
Okay, so you have a cardiac patient, okay, with a patient with dyspnea, okay, in later half of pregnancy, okay, and so the patient is presented in emergency 30 weeks gestational with dyspnea, okay. So what are the possible reasons for this dyspnea?
Um,
Yes.
it may be pulmonary embolism,
Okay.
or it may be myocardial ischemia.
Okay, MI. Okay, so can you divide in pregnancy related and pregnancy not related? Okay, and then in systematic, you can see any system is involved, pulmonary or cardiac. Okay, or what else?
In amniotic fluid embolism.
Before delivery, it's least likely. It can occur. Okay. Okay. So now how will you evaluate? What will be the things you can do? What will be the first thing for you to do? You will do prop up.
Prop up in position, give oxygen, 100% oxygen, and
Okay. You see there is no respiratory symptoms. Okay. And you see that there is raised JVP.
okay.
So what can be the possible cause?
Right heart failure.
Okay, heart failure. So heart failure with low ejection fraction, like signs of failure. What is the, if there is patient does not have any other cardiac disease, so what may be the reason? What is that condition called?
Hypertrophic cardiomyopathy.
Not hypertrophy, peripartum.
Peri-
Okay, peripartum cardiomyopathy. So what will you do then? Would you like to see the blood pressures? Would you like to
Heart rate, blood pressure,
would you like to consult any team?
cardiologist.
What will cardiologist do? Okay.
They will do echo.
What will be the finding in echo? What echo will do in this scenario? Echo will tell ejection fraction. Okay. But
Ejection fraction.
Echo will classify the disease,
classify the
severity of the
disease.
disease.
Okay, severity of the disease. But usually in peripartum cardiomyopathy, would you find anything? Nothing. There is no cardiac disease. Okay.
Okay.
So this is a diagnosis of exclusion. If the patient already was undiagnosed before pregnancy, and in the pregnancy the patient can decompensate. Okay, but if there is no cardiac disease and patient decompensate, this is the diagnosis is peripartum cardiomyopathy, and there will be very low ejection fraction. Okay, so your plan will be to stabilize the patient. Okay, so it will be ABC. You will be starting. There may be need of diuretics. Okay, there may be need of
Blood pressure control, beta blockers.
blood pressure control, blood pressure control, and you have to give some inotrope. So AC inhibitors.
Yes, sir.
What else?
AC inhibitors or ARBs are to be used postpartum, yes, sir.
Digoxin.
And
AC inhibitor risk versus benefit in 20 weeks. AC inhibitors are related to what? Teratogenicity. So if it is later half of pregnancy, and teratogenicity is least likely to occur in the later half of pregnancy. Okay. So you will be discussing the management. The answer was correct that you have to consult cardiologist, but not for echo. Echo will not manage the patient. Okay. You stabilizing the patient. Okay. You just have to stabilize the patient with diuretics, with inotropes. Just stabilize the heart failure, whatever you can. Digoxin may be there if the patient may be, and hi-fi things, ventricular assist device. Okay, and pacemaker.
Pacemaker, cardiac
AICD.
synchronization.
Okay, so these are the things which you maybe digoxin is maybe needed. AC inhibitor, blood pressure control. Blood pressure may be low even. Okay, so you have to use some cardiotonics to increase the, and then you did not mention about obstetrician. You have to discuss with obstetrician. They will be giving the steroid to maintain ops team, then ICU team. It looks funny, but actually you have to distinguish ICU with anesthesia. Okay, so you have to distinguish ICU from anesthesia, and then you have to manage. Okay, so what will be the choice between GA versus spinal if they want to go for cesarean section?
GA.
The same answer which we did give in the last patient, that you will be discussing with the surgeon what is the with the obstetrician what is their plan. The priority is always given to the mother. They will try to linger on the pregnancy, maturation of the baby, but at any time if the patient is decompensating, they will go for the evacuation of the baby. Okay, so in that case you will be discussing with the NICU for the possible, if the baby is immature and they are giving the DEXA steroid cover, and discussion with the NICU team because the baby will be needing to be transferred to NICU. High risk consent, ICU, then GA versus spinal. Again you can think in the same way, that what are the advantages of GA, what are the problems with GA, what are the problems with the spinal, or spinal versus epidural. Okay, so epidural or GA will be choice. Spinal will not be a good choice. Okay, because spinal will have sudden decrease in blood pressure, so it will not be a good choice. Okay, the rest of the things are the same. Risk of aspiration, difficult airway, invasive monitoring, and judicious fluid therapy. Am I right? So you will be using the same answer in every patient. You have to, because this is considered to be a cardiac patient, so you will be having higher transfusion triggers. You will be saying that this patient, if the patient is not anemic or the hemoglobin is low or bleeding occurs, you have to transfuse blood. But at the same time, you have to consider the patient going in overload. So you will have invasive monitoring. You might need CVP. That's how you will make your answer. There is Nothing special you need, only the common sense. There is no specific answer for this patient. Okay, anything you are, and you were so confused to start in dyspnea. So you should be saying that I will be evaluating the patient, I will immediately prop up the patient, I will put oxygen, I will call for help, and then I will with the same answer which I told a few seconds ago. Evaluation management and resuscitation management and evaluation will go side by side. What's the problem in uttering these words? Okay, there is nothing science in this answer, believe me. You will be looking at any cardiac cause, respiratory cause, you will be involving the cardiologist, you will be doing the ECG, might find something. Okay, if there is only dyspnea, that the differential diagnosis is different. If the dyspnea is associated with the low blood pressure, the DD is different. Okay, so this answer should be in your tongue, just to vomit out as soon as you listen the question. Okay, and the same scenario they can ask with some known cardiac valvular lesion. Okay, so in that, the same consideration which are there in any cardiac lesion, ischemia, slow and tight, regurgitation, loose and fast. Okay, but it doesn't mean that you want tachycardia or you want low systemic vascular resistance. You will be again saying then you will not let the SVR to increase and you will not let the heart rate to go down, because if your heart rate goes down in a patient with regurgitation, there will be increased regurgitation and failure. If the SVR is increased, there is increased regurgitation. Similarly, in stenotic lesions, if the SVR is suddenly decreased, patient will not be able to maintain the cardiac output because they have fixed cardiac output. Okay, so if the SVR is suddenly decreased, but it doesn't mean that you need to increase the SVR, because if SVR is too much increased, even then there is problem. Okay, so the rest of the things are the same. Maintain sinus rhythm, maintain normovolemia, normotension, normoxia, normocarbia, avoid stress response, invasive monitoring. What is different? Just tell me. They will be looking for this answer. If you have a patient with valvular heart disease, don't be afraid. The first answer should be, I will be evaluating the severity of valvular lesion on the basis of history, examination and investigation. There will be some signs of failure, there will be signs of decompensation. The evaluation will be on the basis of history, examination and echo. In echo, in regurgitant lesion, you are looking for the ejection fraction, you are looking for any clot, you are looking for any regurgitation fraction, how much is the severity, and in stenotic lesion you are looking for the size, transvalvular pressure gradient, okay, and any left ventricular hypertrophy, any chamber clot. So if there is any chamber clot, you are going the anticoagulation. Okay, so rest of the things are, again I am telling you, the same things, same invasive monitoring, same judicious fluid management, same control of stress, and my best friend, normotension, normoxia, normocarbia, normovolemia, maintain cardiac filling pressures. If you are using this word, I can guarantee you the examiner cannot fail you. Filling pressures means right-sided heart failure. Filling pressures are through how you monitor the right-sided filling pressure, Sidra? You monitor the right-sided filling pressure with the CVP. This is for left-sided filling, left-sided. Pulmonary artery occlusion pressure, you do it with the pulmonary artery, this for left-sided heart filling pressure, and actually they are not very accurate. So you have to trust on the echo findings, okay, whether there is some failure or not. So that's how you are targeting. Okay, so the rest of the things which they can ask in twin pregnancy, nothing special. There will be exaggerated where this supine hypotension syndrome, so you have to make the left uterine tilt. Okay, and there will be because there are two babies, there should be two NICU doctors there. You have to give the uterotolic after the delivery of second baby. Okay, The rest of the things are the same. If they have cord prolapse or placental abruption, this is fetal distress. Okay, so you have to immediately do either general anesthesia, or if you are confident that you can tell about rapid sequence spinal, you can tell. But I think you can keep this answer in your bag. If they are asking, then you can tell. Okay. So the rest of the things they can ask you about labor analgesia. So you have to tell about the basic theory that in first stage you are needing this thing, and the second stage there is additional pressure and there is involvement of somatic system. The people start the answer with the bookish answer, sir. There are non-pharmacological and there are yes, you can start the answer, but as an anesthetist you have to tell the exact answer. Then you can say that you tell about the labor pain pathway, that what is the severity of the pain, and then what is the stage of the delivery, a stage of the labor. And then you can say that you will be choosing some non-pharmacological things which they are doing. You can tell about Entonox. In the meantime, you are preparing for the epidural. The answer can be like this. Then you can give some short-acting opioid. You can give some Entonox in the time you are preparing for the epidural. Okay, and then it is better to place epidural early, around 3 centimeter dilatation, or in primigravida it will take a lot of time. So it is better if they are anticipating, they are planning, there is no contraindication, you have to explain the patient, and that it is better to place epidural early. Okay, and then you will be giving starting the dose. Usually it is around 0.1%, 10 ml per hour, like this. Okay, and you can add 2 mics per ml of fentanyl. Okay, then you can increase it. If they are saying that there is inadequate control, then you can give a bolus dose, you can give a sitting dose, and later on they can they can ask you that what are the choices. So you can say that pudendal nerve block is one of the option, and you can give even saddle block in the second stage of labor. Okay, if then you should be knowing what are the different incidents of different complications which can occur in epidural, like epidural abscess, epidural hematoma, failure, incomplete, partial, how to tackle it, how to evaluate it, that you have to monitor the three systems: autonomic, motor, and sensory. You don't need to give higher dose, because if you give higher dose, motor block will be there and it will be problematic for the patient to push. Okay, there are chances of instrumental delivery. There is no clear-cut association between chances of cesarean section and epidural. Okay, so these are the things which they can ask you in pregnancy. But remember, pregnancy changes, don't forget. Whenever the love word pregnancy has come, so you have to tell that there will be physiological, pharmacological, and anatomical consideration in a pregnant patient that are altered airway, anticipated difficult airway, patient is having low FRC, patient can desaturate, the stomach is full, patient can aspirate. So you have to do the acid prophylaxis, and you have to do the rapid sequence induction, and you have to do the ramp position. You have to be ready for any difficult airway situation. Modified rapid sequence induction, if the availability of Sugammadex is there, it is a better choice. Otherwise you will do the rapid sequence induction, and you will do the pre-oxygenation, and you will be ready for it. And they can ask you about the difficult airway algorithm, or they can ask, in the similar scenario, they can ask you about fetal resuscitation, peripartum cardiac arrest, and the CPR in a pregnant patient. Okay, so other things you will tell that there is altered MAC, there is altered response to medications. So these are the things your answer should be ready, that in any pregnant patient if you want to tell in 30 seconds everything related to pregnancy. You should be practicing it, because this is the answer you have to speak out in the Viva in one way or other. Okay, so any question? Zishan, is it a good review? But you see, you
Yes,
did not answer in a proper way. So you are a leader, so I want your answer to be the best. Okay, so So the rest of the things, if you can listen to the audios related to gyneops. So if anything you don't understand, and I just saw just now that there is a option of transcript. So all the discussions which we did in English, you will have a transcript. You can just actually, it was a surprising thing for me that if you are watching any video, I was just looking here, and I was just because these things are actually new for me. So I was just looking here, and I saw here. I was looking in the mobile. Let me see how to find it here. I just find option of transcript. So in the transcript, all the things
There
were
it was written.
It was written in English. I never knew about this thing. Okay. So this is something which can help you. Okay. So if you don't understand, you can you just see yourself. You will find it. I didn't know about it actually. So even then, if you don't understand anything, if remember one thing, if you want to sit like hen sit on the eggs, and you are sitting on the books, and you are thinking then you will pass, maybe you will pass, but I guarantee you that if you speak out, then their chances of passing are more. Okay. So the people who are in the group and sitting like hen, please, I request, speak out, discuss the question, and I hope that from 8 p.m. to rest of the night, I will be very happy if you people are discussing any questions related to gyneops. Okay. Uterotonics, uterine relaxants, cord prolapse, fetal distress, fetal heart rate monitoring. In the talks they can ask you this question, fetal heart rate monitoring. Okay. So you should be knowing what are the problematic fetal heart rate variabilities. Then they can ask you about epidural. So your answer again should be that I will be discussing the patient about the choice, explaining the procedure, the drawbacks, the shortcomings, and then the possible complications, and then I will be proceeding with anything. And I will be ruling out any coagulopathy, INR more less than 1.5, and platelet count is okay, and there is no other risk of coagulopathy. Okay. So similarly, cardiac things I told you, hemorrhage, hypertension. These are the things which any of the question. And another thing, yes, anything in pregnancy, like diabetic ketoacidosis in pregnancy, you will find it in the playlist. We discuss in detail. Trauma in pregnancy, nothing special, believe me. The same theory, A, B, C, D, same thing. Primary evaluation, secondary evaluation, but you have to tell about this uterine tilt, calling the obstetrician team, and fetal CTG, ultrasound, fetal well-being, discussion with the obstetrician, and this one, if the cardiac arrest occurs, peripartum cesarean section within 5 minutes. Okay. So these are the things which they are expecting. Obesity in pregnancy or anything in pregnancy, the rule should be 1 + 1 will not be 2. 1 + 1 will be 3. Like problem 1, obesity, problem 2, pregnancy. Now it is not 2, it is 3. So the problems are exaggerated. Okay, if you have a morbidly obese patient for cesarean section, you will see the same thing, that there will be chances of OSA, there will be chances of difficult IV lines, there will be chances of difficult spinal epidural, there will be more chances of supine hypotension syndrome. The same, nothing special, believe me. Don't be confused. The same changes of pregnancy, I repeat again and again. Okay. So I hope it was beneficial to you, and tomorrow you can just divide the units. Zishan, you can take the lead and we can discuss. Okay.
Tomorrow, inshallah, regional, sir.
Okay, you can get the feedback from all of you. If you can just write down the units I have discussed, because I'm a little busy, so I may not be able to do it, but you do it, and just I will be there to help you out. I will be very today I was surprised that you people are awake. I received the message from Zishan, and I thought that you people are already become mummified. Okay, sitting like a hen. Please don't consider my words as bad words. It is better to be embarrassed in front of Dr. Zishan, who cannot hit you through his mobile, than to be embarrassed in the exam. Okay, because Dr. Zishan is there to help you out, but examiner will be smiling at you. If I'm teasing you, it is for your betterment. Okay, thank you. Bye bye.
Thank you, sir. Thank you, sir.